Our moderator today is Lisa McGuire, Chief Executive Officer at the Manufacturing Safety Alliance of BC. Lisa?
Thank you, Dale, and all of you for joining us this morning. For those who don't know us, the Manufacturing Safety Alliance of BC is a not-for-profit health and safety association serving the manufacturers and food processors across the province. We invite you to call on us for confidential help with your safety program in response to COVID-19 or any health and safety challenge impacting you. Please visit our website for safety training and resources or information on the Occupational Safety Standard of Excellence core certification enhanced for manufacturers and food processors. It has been a challenging time for all through the second wave that rose quickly with COVID-19 positive numbers in November, enhanced public health office restrictions impacting our COVID-19 safety plans that have continued from November to now. Together with the arrival of vaccines, this unprecedented achievement made possible through global scientific collaboration. This tsunami of change has brought forward many questions from you, the manufacturing and food industry community, about COVID-19 claims and orders in the workplace and the safety effectiveness and rollout plans for the COVID-19 vaccine, especially now with the arrival of variants in BC. Today's webinar is designed to help answer these and other questions that arise in this town hall. Our presenters today are Dr. Monica Naus, Medical Director of the Communicable Diseases and Immunization Service at the BC CDC, Chris Back, Director of Occupational Health and Safety Consultation and Education Services at WorkSafe BC, and Preston Parsons, Partner at Overholt Law. Please feel free to ask questions at any time through the chat window. We will address as many as we can at the end of today's presentation. Welcome to our panelists. Employers continue to have questions on COVID-19 inspections, enforcement, and expectations around prevention programs. Chris, what's happening in BC manufacturing and food processing facilities with COVID-19 orders and claims, and where have you been seeing the biggest gaps in the sector, the most notable challenges and areas of non-compliance?
Yeah, thanks, Lisa, and thanks to everyone for listening in today. So I thought I'd maybe just start off with a bit of the numbers on the prevention side, and I'll come to claims maybe a little bit towards the end. So overall, within WorkSafe BC, we have conducted over 22,000 inspections across the province specific to COVID, and that dates back to the beginning of the pandemic. Within manufacturing specifically, we are just over 2,200, so roughly about 10% of the inspections that we have conducted are in the manufacturing sector. We've also done just over 4,000 consultations with employers, and about 241 of those have occurred within manufacturing. When it gets down to the orders, we are at just over 1,660 orders that have been written province-wide specific to COVID, and about 280 of those within manufacturing. So if we look again at the inspections versus the orders, we're at 2,200 inspections in manufacturing and about 280 orders, so roughly about 10%. And I think what that really speaks to is that for the most part, employers are doing a very good job in developing and implementing their COVID safety plan. We feel that roughly about 80% of the employers are effectively controlling the risk. And then, you know, of the remainder of the 20%, the majority of those are minimally controlling, and a very, very small percentage of just over 1% of what we're seeing are not really controlling the risk at all. So overall, employers are doing a great job. When we then start to break it down into where we are seeing those control measures be successful and where we're also seeing the challenges, approximately, you know, roughly about 60% or so of the employers have really good engineering controls in place, and that would be speaking to the barriers, physical barriers that are put in place. It would be getting into the physical distancing and other controls that would help with elimination of the risk. About 42% of the employers are focusing more so on the administrative controls. and only about 1.7% are only focusing on PPE. And of course, we know that looking at masks alone is not enough of a control measure in place for COVID-19. So really, it's a very, very small percentage of the employers that are not doing what would be considered adequate from our perspective in controlling for that risk. When we then start to look at why, what are the barriers to employers controlling for the risk, it comes down to their ability, their knowledge, and their motivation. And we find in most cases, the employers who are not controlling the risk adequately is because they don't have the ability to, or they don't feel they have the ability to. So they may not have a full awareness of the correct application of the hierarchy of controls. They may not have the right tools at their disposal. They may not understand where the resources can be accessed, and so forth. Part of it is also kind of connected to that, the knowledge. So employers not being aware of the risk or the regulations, and not understanding or realizing where they need to control the risk. Very small percentages related to the motivation, but we do see that some employers, even though they are very well aware of the risk in place, they are choosing not to implement the best or most effective controls. And that's where we're really running into the types of orders that we're seeing. So where are our orders? If you look at it from the perspective of the Workers' Compensation Act and the Occupational Health and Safety Regulation, which is the framework for where our organization can enforce and write orders, most of it comes down to Section 21 of the Workers' Compensation Act, which is general duties of the employer. And this really speaks to one or more significant or high-risk deficiencies in their COVID plan or their protocols, or they're missing key elements, referring to the 6-step process that we have through WorkSafeBC's COVID safety plan template. If they're missing, if any employer is missing a key element or has not gone through one of those 6 steps, then that will likely lead to a Section 21 order. We're also seeing orders being written under Section 5.2 of the Occupational Health and Safety Regulation, which is general information requirement. And this speaks to the lack of written procedures being prepared and implemented to eliminate or minimize a risk of exposure to a chemical or biological agent. Of course, this being a biological agent in this case. And then also under Section 3.3 of the Occupational Health and Safety Regulation, looking at the contents of a health and safety program, and speaks to a lack of appropriate written instructions or available reference for all workers. So if we start to break that down a little bit, really what it comes down to is most of the orders are written where employers don't have a COVID safety plan or don't have an adequate COVID safety plan, so they don't have the appropriate protocols in place. They may, and in some cases they have the protocols in place, but they're just not in writing. And that's important for employers to consider, that not only do you have to have the plan in place, but it needs to be written, it needs to be documented, and it needs to be available to essentially anyone, whether that's a worker, a service provider, or the general public coming into the workplace. So that's first and foremost where we're seeing some of the gaps. We're also seeing gaps in worker health checks. As you're likely aware, employers are required to conduct worker health checks based on the provincial health orders that were written a number of months ago. So we are seeing some employers are not doing an adequate job of those worker health checks. Either it's more of a passive approach where they just have signage up, or they're not doing them at all. So the employer needs to ensure that the adequate health check is happening, an active health check is happening every day for the workers coming into the workplace. We also see some protocols missing, so employers might be focusing on their workers and not on customers or the public coming into the workplace. So your COVID safety plan does need to consider anyone coming into the workplace. Insufficient physical distancing practices, so either they're not in place at all, or they're not supplementing physical distancing with other controls such as barriers or PPE, or they're not staying true to their plan. And we're starting to see this a lot as well, is where employers have the documented plan, but they are not actually staying true to the plan. So they're not supervising, they're not enforcing their plan. They may have occupancy limits listed within their plan, but they're not posted, or workers aren't told about them, or they're not being enforced. Or the plan says that barriers will be installed wherever workers need to work beside each other, but the officer has found that there's actually no barriers in place at all. So you need to ensure as an employer that how you're actually implementing that plan stays true to what you have documented within the plan. And then just a couple other points, Lisa, on this point is, insufficient communication. So when officers are asking workers about the plan, they are not able to adequately describe what's within the plan. So that speaks to the importance of communication from the employer to their workers. Inadequate training, so they're not totally, workers are not completely understanding of what they need to do. It might be related to the proper use of PPE or proper cleaning and disinfecting protocols, or that training has not been documented is also another issue. And then I've also spoken a little bit about the supervision already, but supervisors not necessarily knowing what their responsibilities are, that will lead to orders being written. Same around mask and hygiene use. Or lack of physical distancing in break rooms, punch clocks, equipment areas, locker rooms. So it's important that employers are also considering those areas where workers may congregate, even if they're not doing their duties. So lunch rooms, break rooms, outside smoke areas, things like that need to be considered within the plan as well. And then on the claims side of things, really just a couple minutes on claims here is that a COVID claim is considered work-related when the worker contracts COVID as a direct result of their employment. So they are entitled to compensation if the following conditions are met. So first of all, there needs to be evidence that the worker has contracted COVID-19 and that the nature of the worker's employment has created a risk of contracting the disease that is significantly greater than the ordinary exposure risk for the general public. So an example might be an acute care hospital or a long-term care facility where they are treating patients who have been diagnosed with COVID-19. But please also keep in mind that all claims are adjudicated on a case-by-case basis. When we look at the overall numbers, there's been roughly 3,600 claims submitted since the beginning of the pandemic, and just under 2,000 of those have been accepted to date. The majority of them are in healthcare and social services. So of the 1,960 that have been accepted, 1,470 of those are in healthcare and social services. Within manufacturing, we've seen 86 claims submitted and 36 of those have been allowed. So you're looking at somewhere between a 50 to 60% acceptance rate. But if you start to dig into those numbers a little bit more, what you'll recognize is when we account for that first test being met, so when we look at those claims that are submitted where there is actually a diagnosis of COVID, the claims acceptance rate is actually closer to 95%. So where there is actually a diagnosis of COVID and it's being put forward as a claim, there is a very high acceptance rate within those situations. And if we look at the top 10 occupations, most of those fall within the healthcare and social services sector. And in fact, none of the top 10 fall within the manufacturing sector. So with that, Lisa, I will hand it back over to you. Hopefully that answers your questions.
Thank you, Chris. And it's great to see and hear that the manufacturing industry is doing a good job of putting their COVID-19 safety plans in place. And knowing that it is not a stagnant plan, we have to continue to review and look at our environment, and then of course continue implementing, strengthening those controls where we see the need. So thank you for that. Just a little bit more on the claims. In terms of claim-related, COVID-related claims being denied in the manufacturing sector, what are you seeing in terms of that? Has there been a large portion of claims from manufacturing been denied, or any at all?
Of the, again, so let's just look here. So of the 86 claims that have been submitted, 36 of them have been allowed or accepted. 18 of them to date have been disallowed. And again, I don't have the details on all 18 of those. I mean, I wouldn't have the details of each of those claims, and each of them would be looked at specifically. But again, where we're seeing the majority of the claims being disallowed is because there actually hasn't been a diagnosis of COVID for that individual. But however, going back to the numbers, we still have 20 claims that are currently pending. So hard to say where those 20 will go until they've gone through the adjudication process. And then of the remaining 12, 7 of those have been suspended. And there's many reasons why a claim could be suspended. In some cases, the worker themselves have actually pulled back and decided not to put the claim forward. But there could be many reasons for that. and then also 5 of those no adjudication was required, and again, there could be very similar reasons to why adjudication was not required. So again, roughly about, maybe about 40%, if I'm looking at the numbers here, about 40% are accepted, about 20% have not been accepted, and there's still about another 20% or 25% or so that are still pending.
Okay, thank you, Chris. Very, very helpful. I appreciate all of that information you shared with our audience. Moving on, with the vaccine rollout, we're also hearing many questions about employer responsibility and liability. Preston, what are you seeing in arbitration cases around COVID-19 related terminations or policies?
Thank you, Lisa, and good morning, everybody. It's wonderful to be here today on a rare blue sky day downtown Vancouver. So we have seen some arbitration cases coming up, Lisa, and of course, everybody, all of our audience members, I'm sure, are aware of oftentimes how long things can take to get to arbitration. Certainly in court, arbitration is usually quicker. So we don't have a pile of decisions, but we do have a few. And so with respect to COVID-19 related terminations and policies, there's been one out of BC so far that was really a BC Ferries case in relation to mass layoffs there. And the ability of the employer to use its management rights clause in the collective agreement to affect those layoffs. It was actually determined in the context of that collective agreement that it wasn't up to the employer to use the management rights clause for that, despite the circumstances. But they did say that Section 54 of the Labor Relations Code, which has a 60-day notice requirement for employers for those types of layoffs, that it actually, the pandemic would justify an exemption. And that's a nice thing to have, because we actually rarely see exemptions to that section. Some other arbitration cases that have come up have been in Ontario and are very both interesting, on point, and instructive for us. There's been one where an arbitrator found that the company discriminated against the worker on the basis of family status when they terminated his employment due to their COVID-19 policy. And what that was the worker lived in the US and was one of the workers who crossed into Canada every day. He had children in the United States, and so he was actually exempted by federal law, the category of workers that he was allowed to cross to and from the border every day for work. But the employer determined that they were going to institute a policy that basically mandated federal law without the exemption. So the worker had to choose: do I either move to Canada and keep working, or do I stay in the US with my family? And that was found to be discriminatory. And the employer was lauded for its goals in its COVID policy, but found that it went too far. And that you still needed to consider other things like the duty to accommodate, discrimination on the basis of family status. There's another couple Ontario cases where employers had COVID-19 policies in place to prevent transmission. In both of those two cases, the grievors blatantly breached the policies, and the arbitrator had no time for it. In both cases, the arbitrator upheld the employer's dismissal for cause on the basis that the policies were very important for the employer. COVID-19 is an insidious threat, and given the fact that the workers had really been very careless in how they breached the policy. So those are very strong decisions for the employers on that front. And finally, there is an Ontario decision upholding an employer's COVID-19 testing policy, which required that all employees be swabbed and tested for COVID-19 every 2 weeks at work. The union challenged that. And the arbitrator found that at the time it was a reasonable policy and put into place. So to sum up on that point, we are seeing decisions come down the pipes on these topics. Early indication at this point is that arbitrators are taking COVID-19 extremely serious and aren't putting up very much with employees who flaunt that.
Thank you, Preston. Interesting times for sure in terms of arbitration outcomes. We're begun to see negligence claims against employers related to COVID-19, what do you think are the most important considerations or takeaways for the employers in our audience today?
Sure. So as I alluded to, arbitration cases often get to a decision faster than court cases, and thus far we actually have none. There's been no decisions on negligence policies that I was able to find as of today so far. Sorry, not negligence policies, but negligence claims for employer handling the pandemic. And so we don't have any decisions yet, but in terms of theorizing where it could go, I would think there's obviously two very important things to consider, and this leads off of Chris's comments. The business needs to be looking at, how it's protecting both of its employees and its customers and visitors to the site, and it, potentially could face claims in different from different sectors, depending on the province and things. But, from my perspective, if the employer is following all the public health orders, is staying on top of that, is following all of the guidance in this province from WorkSafe BC, and is, continually updating their COVID safety plan, following it, not just putting words on a page and then forgetting it, as Chris alluded to. If that's all being done, then I think it's going to be difficult for somebody to mount a negligence claim against the employer. I also think judges are going to be quite sympathetic to employers' efforts in this. If they can see that the employer is doing everything they can to follow this, I think that it's going to be hard to mount. And of course, there are some businesses going the extra step and requiring waivers to be signed before you take place in activities on their premises or attend their premises. And to my knowledge, we don't yet have certainly any decisions on the enforceability of a COVID-19 waiver. I'm aware that there's a lot of discussion in the industry that smartly drafted, we can make them enforceable, but yeah, we don't have a decision yet saying upholding one that was challenged in court, for instance. So time will tell. I expect that we're going to see cases with pandemic-related decisions in the civil courts coming out for the next 2 to 3 years.
Thank you, Preston. Much appreciated in terms of providing us insightful information. Moving on. First of all, Dr. Noss, thank you for making the time to join us today as well to address some of the key questions and concerns regarding the vaccine and rollout plans. When the COVID-19 vaccine becomes available to the public, including the essential workers in manufacturing and food processing, what do you see as the key considerations for employers from the rollout approach to the safety and effectiveness of the vaccine itself? I understand you've brought a brief presentation to share with us.
Thank you. Would you like me to go through that presentation?
Yes, we'd be delighted to see it.
Okay, great. I was given the title of Future State with Vaccines Now Available, and just remind everybody that Future State will include vaccines that are not now available and that will be available in the future. And there's been, of course, a ton of media coverage. I've been listening to the US podcasts as well on these topics, and I'm sure that we're suffering from information overload. So I think a lot of the information in my slide set you'll have seen. We're very closely engaged with coordinating the rollout of the immunization program in British Columbia. Our team is usually the team that's involved in immunization programs, the publicly funded immunization programs. The feds, of course, are very closely engaged with this process as well, and that's an unusual role for them, but it's consistent with pandemic response. So just go to my next slide, please. So in the public domain, this information, you'll find it on the Health Canada website. Canada has entered into 7 supply agreements for vaccines, and you've probably heard that these agreements are for financial commitments by Canada, regardless of whether these vaccines ever make it to the market. So at this point in time, the first 2 vaccines listed here, which are the mRNA vaccines from Pfizer and from Moderna, are the 2 vaccines in use in Canada, but we are expecting that there will be approvals of additional products as time goes by. and a lot of the reliance on being able to immunize all of our population in the country by the fall is contingent on having approvals of some of these additional vaccines. Only one of these vaccines requires a single dose. The others are recommended for use in 2 doses, but that's been another controversial area, whether during this time of relative vaccine shortage, we should be using the single dose to administer to as high a number of people as possible in order to provide very good protection and then provide the second dose subsequently when we have additional vaccine supplies. In this province, the recommendation has been to use a 35-day interval between doses, but during this time of relative shortage, during the Pfizer retooling and supplies coming in from Moderna only every 3 weeks, the recommendations are for a 42-day interval. Next slide, please. All of the vaccines, despite the warp speed for their development and for their rapid approval, have been subjected to the same clinical trials that other vaccines that are in use throughout the world and Canada. And those are phase 1, 2, and 3 studies. Phase 3 studies are the ones that we consider to be the pivotal trials in which efficacy, which is, does this vaccine work in a randomized controlled trial? Does it protect against the disease, as well as safety? And safety in phase 3 trials cannot detect very rare events, and those rare events are studied in post-marketing surveillance. In the Pfizer and the Moderna studies, there were 22,000 and about 15,000 vaccine recipients respectively. So rates below about 1 in 10,000 cannot be detected in those types of trials. But I've got some additional information for you so that you have added comfort with this. Next slide, please. So both of the 2 vaccines that we're using right now have really very high rates of efficacy. And this was defined in the clinical trials as the ability to prevent laboratory-confirmed symptomatic COVID infection. And very similar rates. The upper limit of the confidence interval was in the high 80s, and that efficacy was maintained in older individuals, which is very important given that that's where the mortality from this disease is. Safety in the clinical trials, the vaccines were very well tolerated. Majority of individuals had pain at the injection site, and a smaller proportion had redness and swelling at the injection site. An appreciably high proportion of individuals had things like headache, muscle aches, some fever, but most of these were mild. They begin about 1 to 2 days after the vaccination and resolve spontaneously within a day or 2. With the Moderna vaccine, we are seeing in a small proportion of individuals, about 1%, what's called a biphasic local reaction, which is where about day 8 or 10, there's another episode of redness, swelling, and sometimes itchiness at the injection site. But this again spontaneously resolves and is not an indication of an allergy. And the very important thing is that there are no emerging safety signals coming out of the post-marketing surveillance. The adverse events following vaccination are reportable under the Public Health Act in British Columbia, and that's the case in most provinces and territories of Canada. In others, there's a voluntary reporting system, but we also have large scale use of these vaccines in other countries, including the United States, where they have linked databases that regularly search for signals of events like Bell's palsy, like Guillain-Barré syndrome, various autoimmune conditions, and none of these are emerging in those examinations. Next slide, please. The plan for the rollout of this vaccine was very much based on recommendations from the National Advisory Committee on Immunization and considered the features at the top, or the goals at the top of this slide here, which are both to minimize overall deaths while minimizing societal disruption. That's the same that goals that we would have in an influenza pandemic. And therefore, individuals in long-term care facilities, assisted living, and healthcare workers have been prioritized for receipt of the vaccines. And then you'll see that in the government plan, there is contemplation of essential workers later on when the vaccine supplies are ramping up. So next slide, please. I was asked to address why the thrust of the plan in British Columbia is to progress, and in other countries as well, is to progress through age-based delivery of these vaccines. And these are findings that have been observed in all jurisdictions that have examined their data and are based on British Columbia data on COVID cases linked to the administrative databases, largely hospital separation data, it's called. And you'll see here that at every single age band, compared to the reference population of 20 to 29-year-olds, there is an increase in the risk of hospitalization from COVID. So that's highest in the oldest age band at 80 plus. You can see that's a 25-fold elevation of risk of hospitalization compared to somebody in their 20s. But every single 10-year interval below 80 is also associated with an increased risk. So that is the rationale for why age has been identified as the key way to progress through this campaign. It's easy to identify people by age. That's a validated risk factor based on any form of identification. And it's substantially higher risk compared to any single underlying medical condition, and those are shown at the bottom of this slide. And to some extent, obviously, age is a surrogate for the development of underlying medical conditions. So individuals who are older are more likely to have multiple underlying medical conditions. Next slide, please. This is the plan that was announced on the 22nd of January by the provincial government, and it's the plan that's still current. We are in the process of trying to get definitions and clarifications for some of these. So for instance, you'll see that in phase 2, the fourth bullet down, vulnerable populations in select congregated settings. So this has been defined as individuals who are experiencing homelessness, shelters for the homeless, as well as staff in those settings. Correctional facilities are also being sequenced in this, with inmates, healthcare workers, and staff being sequenced somewhat differentially. And then group homes, funded group homes, both licensed and unlicensed group homes are progressing. And there are discussions about mental health residential populations as well. I think that employers are going to see employees getting vaccinated largely in the age-based rollout. Right now, that is slated to begin in April, but is very contingent on vaccine supplies. And it will start from the top, and in phase 2, which is the one that we're in right now, we'll be starting with seniors aged 80 and older, and then subsequently moving down in age. So various individuals in workplaces will be able to get vaccinated at different times. If you're a healthcare worker, you'll be vaccinated sooner than if you're in a retail industry, for instance. And vaccination clinics are in progress of being scheduled. A lot of these have been based in settings or specific geographic areas. You've heard about immunization clinics on reserves, for instance, for First Nations populations. A lot of these clinics have taken place right within facilities, the long-term care facilities and healthcare settings. But mass clinics are also being organized, and there will be ways to register for immunization at those clinics. We do expect that once we have reached stable vaccines, pharmacists and physicians will be engaged in immunization services from their offices as well, very much like occurs every year with influenza. Next slide, please. These are the vaccine supplies for British Columbia that are expected, and in Q1 you'll see the doses from Pfizer and Moderna. This includes both doses for first and second dose, so you need to divide that to figure out what the number of people who can be vaccinated with these vaccines is. And then at the bottom of the slide, these are the current estimates that we've received from the federal government about the number of doses that will be available to us for Q2, which is the period April through June. And the quantities, the 36.8 million, includes currently unapproved vaccines that are expected to be approved. But of course, that's an unknown at this point in time. And then our share in British Columbia is based on a population allocation, and it's about 13.3%. So our share would range from about 2.5 million to 5 million doses over that 3-month period of the second quarter of 2021. Next slide, please. On these last 2 slides with the specific questions that I've been asked to address, and so the recommendations and considerations for employers around control of transmission throughout the rollout. So we do expect that as the months go by and as we have additional vaccine supplies available, both in mass clinics and then subsequent in a variety of other venues, immunization services will ramp up. And by September, all adults will have been offered the vaccine. There are clinical trials being conducted in pediatric populations, and we expect that in the future we may have recommendations for immunization of children as well. But in the meantime, prevention of transmission will need to be maintained. I don't think anybody expects that we're going to have to go on with prevention of transmission at the level that we're doing right now for the rest of our lives. I think that's a really pessimistic approach, even with all of the coverage of the new variants and concerns that they may be less well addressed by current vaccines. I think time will tell, and these vaccines may need to be modified in the future, just like influenza vaccines are, in order to cover the circulating variants. Uptake of the vaccine will be assessed. Every dose that's being administered is being recorded into the provincial immunization registry, and we're tracking what the uptake is around the province. And there's every expectation that rates of COVID will decline dramatically as this program continues to roll out. There's already evidence of that happening in the United States. And in several other localities, there's been a lot of coverage about the experience in Israel, where they've rolled out an aggressive COVID vaccine program. And I think we all have every hope that life will return to normal. Next slide, please. I was also asked to talk about the benefits of Immunization Record and its use. There's been a lot of media coverage also about whether this will become a passport that's necessary in order for individuals to be able to undertake certain types of activities, like attending mass sporting events, for instance. This is not something that we do for any of our other immunization programs. It is critical for assessment of vaccine safety. It's critical for assessment of vaccine effectiveness, because clinical trials give us usually sort of the best approximation of the protection from vaccine, but it's very important for us to be able to assess that in real life situations. And so capturing the immunization record into the immunization registries for those types of evaluations is really critical. Individuals also are provided with a personal record of immunization so that they, if they move jurisdictions, for instance, and for tracking when their second dose is due, that's very important. But we don't expect to be tracking coverage at an industry or a building or a floor rate. I expect that very much like we do currently with influenza vaccine, we will be assessing that very closely in segments of the population, especially healthcare workers. And I think that a lot of questions in this area are still, to be considered and addressed in future discussions and recommendations. I'm happy to take any questions you might have. Thank you.
Thank you, Dr. Naus. Really excellent presentation. I appreciate you putting it together. Very informative for all of us. Is there a target community immunity or herd immunity that you're looking for before we see the real strengthening or relaxing of the public health orders? Is there a percentage that has been talked about?
You know, I think various groups have talked about various percentages. It very much depends on something called the R0, and the R0 is and it's a very simple formula, but the R0 is the number of individuals that each case infects. And that R0 has changed over time because it's very much associated with control measures that are being taken. So things like physical distancing, hand washing, mask wearing will reduce the R0. When COVID initially was identified and estimates were made, that R0 appeared to be somewhere between 2 and 3. In order to reduce or interrupt transmission, you need to have an R0 of less than 1, which means that each individual has to result in or infect fewer than one other individual in order to interrupt transmission. So, you know, it's estimated that about 2/3 of the population would have to be vaccinated in order for us to see that interruption. But it is very influenced by whether our habits change overall. And another very important factor is that we see this with all vaccines. If we don't have what's called heterogeneous mixing, if we have geographically clustered under-vaccinated populations, then we may continue to see outbreaks in those types of populations and settings. So those are the kinds of things that we would be looking at over time.
Thank you. Really looking forward to where you've commented on return to normal. I think all of us are looking forward to a time where we can do more. And I really appreciate you putting your slides together. There will likely be some questions from the audience as well. And just looking at a couple additional questions, maybe for you, Preston. What should employers be considering in deciding whether or how to promote employee vaccinations, or even a stronger expectation for vaccinations? What are your comments around that?
Certainly, it's a touchy area, obviously, because it engages a few different potential areas for discrimination claims. You can have potentially either religious-based claims or political belief potentially based claims, or health potentially. Although given the stats and what information we're having on the vaccine so far, that's encouraging that it's probably going to be hard to maintain a disability. But it's something that's theoretical. Of course, you could potentially have somebody that has some type of an allergy or something to a vaccination. So long as employers are open to making sure that they consider the duty to accommodate, as well as make potentially alternative options, like okay, if you're not going to be vaccinated, you're going to continue to agree to wear a mask and things. There are some policies like that have been upheld. Then I think those are considerations that they're going to want moving forward in terms of promoting it. Just to be aware that there could be some exemptions, and you don't want to push too hard unless you're in an industry that happens to become legislated mandatory vaccinations.
From a privacy lens, can an employer ask for proof of vaccination? Is that something that would even be incorporated in any part of an employer policy from your?
It's possible. I think it really depends on the specific industry, the nature. For instance, we've just seen devastation across the country in long-term care facilities and things. It's possible that requiring proof of vaccination for continued employment in that setting, potentially wouldn't be unreasonable. actually the Office of the Information and Privacy Commissioner in Saskatchewan has already put out some information on this, saying that mandatory vaccination or proof of vaccination may be acceptable so long as the employer is going to make very clear to employees what the purpose is of the data that they're collecting and follow all the different requirements of privacy legislation, which in BC for any private employer would be PIPA, Personal Information Protection Act. So you need to make sure that you're advising them why you're collecting the information, where it's going to be kept. It has to be securely stored and not kept for any longer than needed, for instance. So there's a few different parameters around that, but it is potentially possible to require proof.
Thank you, Preston. A lot of still unknowns, but I think we're all working through this in this tsunami environment where things change so quickly and quite significantly.
Yes.
So on that, thank you so much, Dr. Noss, Chris, Preston. This is such valuable information for employers and workers. Looking at questions from the audience as well. To all of you, if you have questions, please submit them through the chat window while we have our panelists together with us. We would welcome any questions. Okay, here they come in. Thank you. Many questions around daily health checks. This is for Chris. How would you suggest the large employer that runs 24 hours a day, 7 days a week, perform daily health checks? Would a daily health check questionnaire fulfill the requirement of health checks? And is documentation of health checks required each day for any employee or contractor or visitor on site? What is the expectation of documentation that an officer is looking for this self-assessment?
Thanks, Lisa. Yeah, so with the daily health checks, I mean, there's a number of ways that could be done, and I would actually recommend that folks take a look at our website. And I'm actually just going to pull it up here while we're talking really quick, so that I can refer to the information that we've got on our website. So we've got a lot of information up there that would be valuable to an employer. And I think what's important to understand is that employers do need to ensure that the health checks are occurring, but this can be done in many forms. Some examples might include a written health check declaration completed by the workers before entry. There could be an online health check form completed by workers before entry, even depending on the size of the employer. And I understand the question's coming relative to a large employer, so this might not be feasible, but for smaller employers, even a verbal health check done either in person or virtually or over the phone for every worker confirming that they've completed the health check is a possibility. Other forms of supervised daily health checks could be considered as well, as long as they are occurring, as long as the employer is putting the processes in place to ensure that health check is being done. So to give you an example, signage on the door as workers walk in is not enough. The employer needs to be doing more than that. They do need to ensure that every worker coming into the worksite has done a health check. It does not necessarily need to be documented, and in fact, there could be some issues from a privacy perspective, and Preston might be able to speak to that more than I can. But there could be even issues from a privacy perspective on the documentation related to that. So we, from WorkSafe BC's perspective, don't necessarily require the documentation to occur on a daily basis, as long as the employer can demonstrate that they are ensuring every worker goes through that health check on a daily basis.
Thank you, Chris. Preston, do you have something to add to that from a privacy perspective? Is that something that you're seeing in arbitration cases?
Not in arbitration cases on that specifically, although there have been a couple arbitrators that have noted the importance of contact tracing. So to some degree, given that obligation, it can be a bit tricky to keep it simply entirely keep the information entirely contained that somebody has symptoms in the workplace or something, because you may need to alert other people that they worked with or whatnot in order to effectively contact trace and clamp down on the transmission as soon as you can. So it's a bit unique in this situation. It is, of course, potentially sensitive medical information that an employer has to handle carefully. we're just in a very interesting time whereby that information is deemed a little bit less private, given the overriding goal in trying to clamp down on transmission. But I definitely take Chris's point about, you know, where there are being records maintained of that. You know, you don't want to leave them out in public. For instance, somebody should have control of them and have them you know, dedicated to one place.
Okay, so added to that is another question on that relates to privacy. Can we ask for proof of vaccination? And if a worker does get vaccinated and reports a side effect, do we need to report it, or is that the person's responsibility?
The latter part of that, I'm not 100% sure on, to be honest, as to whether it would be whether the employer would have an obligation to report about that. It's a good question. I'd have to look into that. But on proof of vaccination, again, I think it's really going to depend on you've got a policy in place. You've explained to everybody, you know, why it's needed, and you know, really, it's important, I think, to think through the consequences of the policy if you're going to put it in place. So if you're going to require proof of vaccination, what if they say no? If your employees say, well, sorry, I'm not going to provide it to you, I'm not going to tell you whether I did or didn't, are you going to be able to terminate their employment? Are you comfortable with that? So I think it's important to assess, you know, your specific work site, your specific industry, potentially different classes of workers, and whether they, you know, it's important that it be demonstrated, proved for their continued employment that they have taken it or not.
Thank you, Preston. Dr. Noss, how concerned are you about the effectiveness of the vaccines with the new COVID-19 variants that are showing up in BC?
Thank you. I'll answer that, and I can also briefly just respond to the question about who's responsible for reporting of adverse events. I think everybody's concerned about the variants. I think from a number of fronts. One has been the transmissibility. One has been what something we call case fatality rate. You know, are they potentially in the future, or some of them, going to be associated with more severe disease? And then thirdly, are the vaccines that are currently being developed going to be effective against these variants if the basis for those vaccines has been a slightly different variant? So I think this is an emerging area. I think the vaccines will probably have some variable performance against the variants. And it may be that we're going to have to continue a nimble process within the manufacturing industry, within the vaccine development industry, about you know, novel strategies and additional strains. So as you know, our influenza vaccine is formulated each year to protect against 4 strains of influenza virus, and these strains change every year based on what's been circulating in the northern hemisphere. A lot of that reliance is based on what's circulating in the southern hemisphere, where the season is all year round. And I think a very similar approach might eventually emerge with COVID as well. So these vaccines may not stay the same. And some vaccines, like the mRNA vaccines, which have a much shorter manufacturing cycle, may become preferable as a result of that. So those vaccines have been hard to handle in the cold chain because of the freezer requirements, but they've been fastest to the market, and they provide very high levels of protection. So those will be decisions that we'll have to make in the future. In terms of reporting of adverse events, it's healthcare professionals who need to report adverse events. So individuals who seek medical attention for those events, that's the point at which the healthcare professional would form the opinion that an event may be associated with receipt of a vaccine. They don't have to have absolute certainty, but if alternate explanations are apparent, then they wouldn't be reporting, you know, everything that happens to a person after vaccine necessarily, just events that they believe could have been associated with the vaccine.
Thank you, Dr. Noss. Is Canada funding any Canadian companies for a vaccine development?
I think that there's a couple. I've even heard, well, there's a group in Saskatchewan called VIDO. There's Medicago in Quebec. They have a plant-based vaccine under development, and they were listed in the 7 companies with advanced purchase agreements. And I think we heard this week that there's going to be some additional manufacturing of vaccine, both in North Carolina and in Quebec. So yes, there are a number of vaccine initiatives, but they're not going to be, early. They're not going to be culminating in any vaccines coming to market during the timeframe between now and September.
Thank you. Thank you all. And I know there's more questions, and we will certainly do our best following this webinar to follow up with all of you for your questions and answers. Unfortunately, we are out of time, but thanks for all your questions today. If we weren't able to answer them, we will certainly do so in our COVID-19 FAQ on our website. I would like to once again thank our presenters for joining us today. The information you shared with us is so valuable for employers and the manufacturers and food industries. Thank you. If we missed your question, please check back on the COVID-19 FAQ page or call our health and safety support hotline to talk with us or a safety advisor. A reminder to all of our manufacturing members that nominations are open for the 2021 Safety Excellence Awards. Don't miss this opportunity for recognition at the 2021 Safety Pinnacle Awards on June 3rd. Thank you all for joining us today. Please click the survey link in your inbox to share your feedback and suggestions quickly to help us improve future webinars. We'll email you tomorrow with a link to the recorded webinar, slides, and all of the resources. Feel free to share these and follow us on social media for more news, resources, and future events. Thank you all.